Yes.
Okay. Good afternoon, everybody. It's a little 1 minute after 12:30 Central Time,
Yes.
so we're going to go ahead and get started. Hello? Yes? So welcome to our 2020 Stroke Educational Series, Wake Up Stroke and When to Treat. My name's Deb, and I will be your moderator today. Feel free to ask questions throughout the presentation by either typing them in the chat box on the right hand of your screen, pressing the microphone at the bottom of your screen, or if you're using a phone, you can audio press *6 to come off of mute and *6 to go back on mute. Our speaker today is Stephen Warwick, MD. He's a vascular neurologist and neuroscientist noted for his contribution to brain imaging of stroke, particularly advanced MRI methods to image aspects of cerebral vascular pathology, improving sensitivity and accuracy of diagnosis and developing novel imaging markers for biologically based case definition and outcomes in clinical stroke trials. He has led seminal studies validating and introducing into clinical practice diffusion-weighted MRI as an early diagnostic test for stroke, the diffusion-perfusion mismatch as a marker of ischemic penumbra in stroke patients, and the novel use of multimodal MRI as a selection tool and outcome measure in stroke clinical trials. Dr. Warwick established an academic and clinical stroke centers in Boston, metropolitan Washington, D.C., and Austin, Texas. He was founding chief of the Division of Cerebral Vascular Disease at Beth Israel Hospital, Harvard Medical School. From 1999 to 2011, he served as founding chief of the section of stroke diagnostics and therapeutics in the Division of Intramural Research at the NINS, creating and managing stroke centers and vascular neurology fellowship at 2 Washington, D.C. area hospitals. He currently co-chairs the NID Stroke Common Data Elements Working Group and is co-founder and immediate past chair of the Lone Star Stroke Research Consortium, a clinical research network across the state of Texas. Dr. Warwick is a fellow of the American Heart Association. He's been a volunteer supporting the American Heart, American Stroke Association in many capacities, serving on both Mid-Atlantic and currently the Southwest affiliate boards, program committees of both the International Stroke Conference and scientific sessions, and several scientific grant review committees and the editorial board of stroke from 1999 to 2011. He is currently professor of neurology in Dell Medical School at the University of Texas at Austin, where he's the executive director of Seton Dell Medical School Stroke Institute, where he also serves as a stroke medical director for a network of 10 hospitals in Central Texas. I will now turn over the presentation to Dr. Warwick. You can go ahead and go. Thank you, Dr. Warwick.
Well, thank you, Deb, for that very nice and lengthy introduction. And welcome all. We normally do this as a webinar, but it feels like we're all missing the direct human contact. So I'm a little bit sorry we won't be able to converse, because that will make this type of a presentation better. But do send your questions by or afterwards. Do mute your microphone if you're not speaking, and let's get started. I have these disclosures. We will be talking about off-label use of intravenous alteplase for treating ischemic stroke, that is, treating stroke beyond 3 hours. I will also disclose I'm a consultant for Genentech, who makes alteplase and tenecteplase, although we won't be talking about that, although I'm chairing the current tenecteplase trial for them called the data monitoring committee called Timeless. And somebody still has their microphone on, it sounds, so please do mute everyone. Here's the overview of the talk. I'm going to begin by just giving a very global overview of some key concepts in stroke and stroke biology and stroke management. Talk about the idealized imaging selection criteria that have been discussed in the literature, but I really want to spend most of the time going through the clinical trial evidence for wake-up stroke and then talking about unanswered questions. And when I'm referring to wake-up stroke here, what I'm really referring to, not just the people that go to sleep and wake up with their deficit, but really unwitnessed onset in which the time from last known well is greater than 4.5 hours. So within 4.5 hours, we consider that standard of care. Beyond 4.5 hours is not fully standard of care yet, but that's what we're going to talk about and review with you the evidence about why and when this might be the appropriate treatment. I will just be talking about IV thrombolysis. You all are very familiar with the literature on thrombectomy and the criteria for treating thrombectomy are well worked out. In fact, our next topic next month will be with regard to large vessel occlusion and how to identify those for treatable thrombectomy. So when we think about ischemic stroke, what is ischemic stroke? It is focal cerebral ischemia. So therefore, the biological target of reperfusion therapy is that focal acute cerebral ischemia, and with the ischemic penumbra, that area of at risk, but not yet infarcted tissue, that if one could achieve early and effective reperfusion, the tissue at risk could be salvaged and the damage attenuated from the stroke. Of necessity, in the past decades and the early years, I'm getting a message that I have a lot of static, so I don't know if that's really one person's a problem. Of Deb, can you tell me whether it sounds like I've got a lot of static going on? I am plugged in and on my headset, so I wouldn't think so.
I hear some, but not too much. But if everybody would either *6 if you're on the phone and make sure you're on mute, or if you have a microphone, then just make sure that your microphone is on mute. And you can just toggle at the bottom of the screen there, and you can mute yourself. Thank you.
Thanks. And I'm getting a lot of messages that it's clear, so it may just be the issue with the one person in the laptop. So what I was saying of necessity, since we started in the thrombolytic era for a stroke 25 or 30 years ago, we have used just the clinical exam and the non-contrast CT to select patients. And with the emphasis on time, that is early time, as close to onset as possible, is the clinical surrogate for the probability of having this target of focal cerebral ischemia with a penumbra. That's why screening just with a clinical exam and non-contrast CT works to effectively treat with thrombolytics in the early time window. But the probability of that treatable target decreases over time with high inter-subject variability. I'll show some examples of that in the next couple of slides. For wake-up stroke or other unwitnessed stroke, the onset is defined as the time last known well, with one exception, which is why the asterisk for trials we'll discuss, because there is a decreasing benefit and increasing risk over time. So in defining stroke onset, we've always taken the conservative approach is what is the longest time it could be, because we didn't want, especially in the trials and the early time point window, we didn't want patients who were at a prolonged time than we think was safe. So in the ideal world, again, we talked about what was of necessity back in the 90s when all of these trials and initial therapies were starting. In the ideal world, we would like imaging that could confirm the presence of an acute ischemic stroke and the presence of that target penumbral mismatch, and be free from any imaging predictors of symptomatic intracerebral hemorrhage, that it's a major and feared complication of thrombolytic therapy. Over those last 25 years, a lot of experience have identified factors, imaging factors as well as clinical factors that predict the increased risk of hemorrhagic transformation, particularly symptomatic hemorrhage. Extensive CT attenuation, it started as calling it the 1/3 middle cerebral artery rule. Now we use aspect scores. Flare hyperintensity, if there's an MRI, low ADC, very low ADC on MRI predicts hemorrhagic transformation. A very large strokes, core volumes, either by DWI or aspects. An extensive chronic microvascular disease seen as extensive, severe leukoariosis, or many cerebral microbleeds on MRI, greater than 10 is the number often quoted. So here's the relationship between time from stroke onset on the x-axis, onset to treatment time, and the probability of having a disability-free outcome, that is a modified Rankin of 0 to 1 at 90 days. This is from pooled analysis of all the randomized trials of alteplase versus placebo, and all the patients selected, imaging selection limited to non-contrast head CT. And patients randomized in that way, selected in that way, the window of efficacy closes right there at 270 minutes, 4.5 hours. And that's why we consider that to be the time window for early thrombolysis. Repeat that that graph on the lower left. On the right side is from a study we did when I was at NIH, showing the decreasing probability over time of having a diffusion-perfusion mismatch, or the imaging signature of an ischemic penumbra. And note, they both decline over time. And it's been recognized that one of the reasons the efficacy of TPA declines over time is that over time, the subjects, the patients, are less and less likely to actually have the target mismatch. This is from data that came out of the diffuse-2 trial. Now, diffuse-2 was a thrombectomy trial, and so, but they selected patients based on a mismatch pattern on MRI. And what this graph illustrates is what has been called the slow progressors and fast progressors. What you see here is on the x-axis, the time between symptom onset, time last known well, and when the MRI was obtained, and then the volume of the lesion on the initial MRI. What you see here is some patients really early on, let's see, this one, which is less than 3 hours, can have very large lesions. Most of the ones early on have small lesions. Some patients very late, and these are patients with large vessel occlusions, ICA or MCA occlusions, can have very small lesions. And this was the basis of why the late, that is beyond 6 hours, thrombectomy trials were successful. They chose those patients, they chose the late responders. The point here is not everybody has the potential to be a responder beyond 4.5 hours or beyond 6 hours. And so it was needed to have a method to select and identify those patients that might. Now, there's also been, in looking at the wake-up stroke, there's been interest in identifying, even with non-contrast CT, those that might benefit. And I'm going to show in the next 3 slides 3 different studies, 2 with CT, 1 MRI, to identify patients who might actually be in the early window, but since they woke up, you don't know did the stroke happen right before they woke up, and that's what woke them up, or did it happen soon after they went to sleep. All 3 of these studies limited the time between when the patient was first noted to have their symptoms and when they got the lytic. So potentially they're still being treated within the true 4.5 hour window from last known well. I show this first study from Andrew Barreto and colleagues coming out of Houston. It was published in 2016. 40 patients were studied. The age limit was up to 80. These were the full range of severities up to an NIH scale of 25 with a median of 6.5. Typical exclusion criteria for hemorrhage or really large ischemic changes. They had to be treated within 3 hours of symptom discovery. And the mean time from last known well to treatment was 10 hours. And in those 40 patients treated with alteplase, treated with TPA, there was no control group. This was just a sample, a single arm sample. There were no symptomatic ICH or no parenchymal hematomas. A very analogous study was subsequently published out of Hopkins with an N of 20. Here, the time between treatment discovery and the lytic was 4.5 hours, so a little bit broader. Very similar mean time from last known well to treat, about 10 hours. And also, no symptomatic hemorrhage, no parenchymal hematoma. So these patients were allowed to have some changes, some early ischemic changes, but not of the kind that would exclude them from typical thrombolysis. So 60 of those patients, no serious bleeding. I was involved with a study that was part of the NIH SPOTRIAS. This was a collaboration with Lee Schwam and colleagues at Mass General, using an MRI pattern, the so-called diffusion positive and flare negative to select patients. And this was based on a study that we did at NIH where we took patients that had witnessed onset. So we knew clinically when the clinical onset and therefore when the ischemia began. And we looked at their MRIs and we looked specifically at their flare MRIs and tried to determine at what point could we say that this was clearly under 4.5 hours, but just based on the flare signal intensity. And what degree of flare signal intensity. So the sweet spot seemed to be a 15% increase. So if the flare signal intensity was not more than 15% higher on the flare region that was corresponding to the DWI lesion, then the contralateral, that was a really strong predictor that the patient was within 4.5 hours with a sensitivity of 0.8, positive predictive value of 0.82, accuracy of 0.73. So that's what was used in this trial called MR Witness, which was, again, a single-arm study looking primarily at safety, choosing the patients if they had this diffusion positive, flare negative pattern, and gave them standard dose IV TPA. And of those 80 patients, here the age went up to 85. They had a median NIH score of 7.5. Similar exclusions for bleeding, obviously, or really large lesions on DWI. Also treated within 4.5 hours of symptom discovery. Here, the time from last known well to treat was 11 hours. Out of those 80, there was one symptomatic hemorrhage. So that met our objective of the study, which was, would the symptomatic hemorrhage rate be within the range of what was seen in ECAS-3, which, of course, broadened the time window out to 4.5 hours for the first time. Now, now I'm going to talk about 3 randomized, placebo-controlled, blinded trials of IV alteplase versus placebo in the 4.5-hour time window. All of these studies were eventually stopped because of either slow enrollment or the end of their funding or both. 2 trials, Wake Up and Extend, nonetheless found statistically significant benefit with alteplase. The third study, ECAS-4, was enrolled less than half of their sample. They had a positive trend, which was not significant, and clearly they were underpowered from what their initial target sample size was. So let's talk about Wake Up. Now, this was done in Europe, and it was done, we had been in close contact with this group as we were developing our studies and they theirs. They used the diffusion positive, flare negative design, but not in a quantitative way. They did not, to enroll patients, they did not measure the signal intensity, but more used a qualitative assessment about whether there was clear hyperintensity. As described here, they initially had planned 800 patients to be enrolled. The trial started in 2010, and it was in 2017 they were informed by their funding agency that they had to end the trial because the funding was not going to be continued. This was similar to the prior studies talked about. They had to get their treatment within 4.5 hours of symptom discovery, but their last known well was beyond the standard 4.5 hour window without an upper limit. So it was purely based on imaging. There was no upper limit to the time window. Maximum image is 80. They had to be treated within 4.5 hours of symptom recognition, as I said, and have the diffusion flare mismatch. And this was 2010, before the 2015 explosion of positive thrombectomy trials. But nonetheless, thrombectomy was happening back then, and any patient who had a planned thrombectomy was excluded, and then all the standard TPA exclusion criteria. And here's just another example of diffusion positive, flare negative, diffusion positive, flare positive would not be eligible. And the top line result, even though, as I said, their target was 800, they had to end at a time when they only had about 500, but their target of achieving a Rankin of 0 or 1 at 90 days was statistically significant, 11% greater for the alteplase than placebo, 53 to 42. They've since done secondary analyses and looked at other factors that were interesting. Now, they weren't limiting the patients to any particular vascular territory. And so they subsequently looked at the small subset that had brainstem cerebellar and did not show evidence that they were doing worse. They looked at lacunar strokes, and there actually was a trend that the efficacy was there as well, but certainly did not do worse. They then, in this post hoc analysis, looked at the quantitative signal intensity ratio on flare and found as flare signal intensity increased, the probability of good outcome decreased. The flare signal intensity was an indication that there was a tissue core that could not be salvaged. Only about a third of the cases, interestingly, that many of the cases had perfusion imaging done, but of those that had perfusion imaging done that also had the diffusion flare mismatch, only about a third of them had what they called a double mismatch. They had diffusion perfusion mismatch as well as a diffusion flare mismatch. And in that small subsample, they found no additional benefit by having a diffusion perfusion mismatch, a penumbral mismatch. So that's Wake Up, and it's now in the American Heart Association acute stroke guidelines, shown here at a level 2A recommendation. And you'll note that the recommendation pretty clearly sticks to what the trial found. Wake Up or unclear time of onset greater than 4.5 hours from last known well, and a diffusion positive, flare negative, and that they be treated within 4.5 hours of symptom recognition. Now, these guidelines were updated and included all the clinical trial data that was published in the literature by April of 2019. The next trials I'm going to talk about actually were published after that. Now, and they have to do with the diffusion perfusion mismatch. Now this is a case that went on to thrombectomy, just to remind us all that it was doing this type of penumbral imaging, core penumbra imaging, either by MRI, which is diffusion perfusion, or by CT perfusion, where there are criteria for core and penumbra. That revolutionized thrombectomy. That is, for those that were around and following this literature in 2015, there truly was an explosion of positive trials, about a half dozen positive trials of thrombectomy, all but one based well, they were all based on imaging. And those trials showed that patients that were selected with mismatch were much more likely to have positive. And then the two 2017 trials of DAWN and Diffuse 3, which specifically used perfusion imaging, found that beyond 6 hours, it was the perfusion imaging and the imaging of a penumbra that led to efficacy. So there was a lot of interest in this, and it goes way back. In fact, these trials I'm going to talk about are called Extend and ECAS4. These were designed around the same time in the early 2000s, before 2010. I'm going to show here in the next slides a comparison of Wake Up to Extend and ECAS4, which those latter two are almost identical, just to give you an insight into how to think of these studies and interpreting them. No upper age limit for Extend ECAS4, similar pre-stroke Rankin of 0 to 1, similar NI-stroke scale. Here's a big difference. The time window for Extend and ECAS4 is 4.5 to 9 hours. It includes Wake Up, and this was the asterisk from the early slide, but they defined Wake Up not as truly the time last known well, but because of uncertainty about when during the sleep period the stroke occurs, they defined it somewhat arbitrarily as the halfway point between bedtime and awakening. Extend used either MR or CT perfusion, ECAS4 MR perfusion. They both used, Extend used rapid to define the target. There was in ECAS4 a locally defined target, but used similar criteria, a percent mismatch of 1.2, meaning it had to be at least 20% greater, and a minimum mismatch volume of 10 cc's here, 20 cc's for ECAS4, but evidence of a penumbra, evidence of lack of a very large stroke, differently defined, 70 here, 100 here. I will say that when the studies were done, this mismatch volume and mismatch percent at its median were not at the boundaries. It was a very small mismatch core, very small core, and a very large mismatch volume. So even though those were the minimum, most of the patients that were eligible were way beyond the minimum and had pretty substantial mismatches. Primary outcome was Rankin 0 to 1 or the Rankin orbital shift. This is interesting. Here's where we were for the planned sample size versus the actual sample size. Now, these two, Extend and ECAS4, pretty much ended after Wake Up was positive and people started to use Wake Up criteria. They realized, the enrollment was slow to begin with. They realized it would be even yet slower, so they wrapped up their studies. And it was a more severe NI stroke scale than Wake Up. Was one of the potential criticisms of Wake Up. It was skewed toward very mild. In Wake Up, 94% of the patients were truly Wake Up. In Extend ECAS4, that was 2/3. 22% of the sample of Wake Up had large vessel occlusions, Again, about 2/3 in extent had large vessel occlusions. Again, that did not go on to thrombectomy. It was yet another reason why enrollment was slowing down to make the continuation of these studies impractical, is we were now in the thrombectomy era and patients were going to thrombectomy rather than to be randomized to the trial. I'll return to this later, but let me just show you the key results. So, as I said, this was published after the guidelines had completed their literature search. So these results didn't make it into the most recent AHA acute stroke guidelines. It was published in May. And here's the top line results, either as the bar chart, but look down here for alteplase versus placebo, 35% to 29.5%. This was adjusted, pre-specified adjustments based on age and severity. It was significant, 0.04. So this was really promising, and almost, I think it was later that month, published online in The Lancet, was a planned pooled analysis of 3 trials. It was the Extend, ECAS-4, and then a subset of wake-up strokes from the old Epithet trial, which had randomized to alteplase versus placebo in a later time window, patients that had a diffusion-perfusion mismatch. So the results of this analysis, when pooled, showed almost the exact same proportion of difference. Alteplase, now the columns are swapped relative to the last one. Alteplase here, 36% achieved the Rankin of 0, 1 at 3 months versus 29%, which was statistically significant. Significant was also functional independence, that is Rankin 0 to 2. Early neurologic improvement. There was increased death and symptomatic hemorrhage was significantly increased. The increased mortality at 3 months was not significant. Symptomatic hemorrhage rate of 5%. And raised a lot of questions. Were there differential effects based on the studies and so on? So this was the overall patients. These were the patients, with, on the right, the patients with that had the target mismatch after analysis, showing in the subgroups there was really no interaction. And the one who was people wondered most about are the patients that had large vessel occlusions versus those that didn't. And again, remember, these were large vessel occlusions that did not go on to thrombectomy. So these were large vessel occlusions here treated only with an IV lytic in the later window with a target penumbra mismatch. And here you see, it doesn't advance as I move my cursor around. You see down here is where that is. And there was really, certainly no interaction between the LVO and the treatment. But the point estimate for both of these subgroups are quite similar. So the effect seemed to be very similar for subgroups. So interesting studies, I think, that have begun to change the way we practice. There are many practitioners who feel that they'd like to see more data still. And there are a lot of questions that are unanswered. One question is, is non-contrast CT, as shown by those initial 2 studies, sufficient imaging if you treat within 3 or 4.5 hours from symptom discovery? And there may be further studies on that. Then the question is, if there's a large vessel occlusion and the patient is planned to go to thrombectomy, now those were excluded from the trials I mentioned beyond 4.5 hours, is IV thrombolysis beneficial? And this is the subject of the Timeless trial that Genentech is sponsoring and I'm involved in, looking at, not at alteplase now, but at tenecteplase in this placebo-controlled trial, and that's an ongoing trial right now. So we saw this small subset, the post hoc analysis in Wake Up, of those that had the so-called double mismatch, the diffusion flare mismatch, and also the diffusion perfusion mismatch. Is that really the ideal case? I can tell you in my practice, I like the reassurance of having a core penumbra big mismatch before giving a thrombolytic in that time window. What about generalizing the results of Wake Up and Extend? You saw there was an upper age limit, upper NIH stroke scale. The one that we encounter probably most often is not just age, but level of pre-stroke modified Rankin. If they were a 2, they wouldn't have made it into these studies. And we generalize that to say those patients could also be treated. And then is the treatment really time independent if you have the ideal target present, if you do the ideal selection? That was for Wake Up. They had no upper limit of time from last known well. The patient was beyond 4.5 hours, and they had the prescribed target of diffusion perfusion mismatch. They were enrolled in the trial. And then the question of, do we really need quantitative threshold imaging? Do you need to actually measure the signal intensity of the flare? Do you need to do threshold segmentation, such as a program like RAPID does? Or is the target, particularly the small core, large penumbra target, so obvious, as it is in most of those cases that were in those trials, that you can just take the data right off of the scanner and make the decision? These are unanswered questions. These are questions that are being investigated. I hope we'll get answers to those soon enough. So let me summarize where we're at, and I would say this is happening. IV thrombolysis beyond 4.5 hours. In 2 circumstances, I have penetrated into clinical practice. This first slide is based largely on the Wake Up trial. So in patients that have Wake Up stroke or unwitnessed onset, and the time from last known well is greater than 4.5 hours, we consider treatment with IV thrombolytic if the age is 18 to 80, pre-stroke Rankin is 0 to 1. You can treat within 4.5 hours of symptom discovery. NIH stroke scale is less than 26. And you're not dealing with a very large DWI lesion that is greater than equivalent of 1/3 approximately of the middle cerebral artery, or greater than 100 cc's. Treated in this way, there's no upper limit to time last known well. That is, there's no time window. Patients in whom thrombectomy is not planned, any vascular territories, it's not just MCA, it's not just anterior circulation, any vascular territory was eligible. And as I said, they've done sub-studies suggesting that there's no indication that the posterior circulation has worse outcomes. And here are the key imaging criteria. The DWI is positive. I think it goes without saying, it's positive in the region that matches the clinical stroke syndrome. So sometimes you can see other DWI lesions, but if they don't have a DWI lesion where you think stroke clinically is localized, that doesn't count. And if the flare is negative, one can measure it if unsure, but Wake Up didn't require that. Remember that the greater the flare signal intensity, the less likely they are to benefit. So that's based on the wake-up trial. Here, based on the extend trial and then the meta-analysis combining extend, ECAS-4, and the wake-up strokes from the epithet trial. Here, there was no upper age limit. Again, the pre-stroke ranking was 0 to 1. They were had no disability. An ICE score between 4 and 26. This is now between 4.5 and 9 hours. So there is a time window here. But for the wake-ups, that time is defined as the midpoint between bedtime and awakening, not the conventional time last known well. Again, thrombectomy not planned, because those patients generally would go straight to thrombectomy. Again, an antivascular territory and a perfusion CT or MRI diffusion perfusion that shows the target mismatches as defined by the trial. And I've been seeing a lot of comments in the chat, which I haven't been able to read since I was reading my slides. But this is my last slide, and I'm hoping we have a chance to have questions and have discussion. So those are my slides, and I'm gonna stop sharing. And Deb, I think you've probably been tracking all the comments.
Yes, Dr. Ward. So if anybody has a question, you can *6 to unmute and ask your question or type it in the chat box. For right now, what I'm seeing is, would you please send us the titles of the articles used was one of the questions.
Okay, I did put that in the slides.
Okay.
I'm happy to share the slides if people want that. I did see that.
Okay, that was the second question.
Yeah.
And they're saying that it's
the trials. Yeah.
Okay. Any other questions from anybody? *6 to unmute or type it in the chat box.
Well, can I ask people, are you doing this at your centers? Are you treating outside the 4.5 hour window if they meet these criteria? We'll look at the chat box. Yes. I'm missing, so the comments are coming in. I'm not getting them all.
Okay, let's see. How did you overcome getting MRI to be available for rapid scanning?
Well, you just have to talk to the hospital and the radiology department. We had MRIs in close proximity to the emergency department, which helped, and we worked out just a procedure with and this isn't just our center. Obviously, there's a lot of centers that are doing it with safety screening, metal screening, and not everybody can get an MRI, of course, but there are, again, CT criteria.
Okay, next question is from the critical access hospital perspective. If you're going to seek advanced imaging, what would you suggest as a well-rounded package of imaging? Non-contrast CT, aspects, ICH, etc.
Oh, it was the question, what images should you obtain routinely, or I didn't quite get it, or what hardware you should be getting in your hospital, or what it should be the standard imaging protocol? Well, let me answer the latter because I think that might be more useful. So I think it's going to largely depend on what resources are at the hospital, right? I think more and more centers are doing what we do and what we do at our comprehensive centers and even our primary stroke centers now is in all stroke codes, we get vascular and perfusion imaging. And this was a contraindication to that on the patient's part. And why not? And even before we would give, IV thrombolytic within the normal, the early time window. Other centers don't do that. Other centers do everything based on initial non-con CT and then bring the patient back for further imaging. So I think there's two approaches. And again, when I say we, I'm not just talking about our center, because there are lots of centers that do it this way. We found that overall it winds up saving time to do particularly the perfusion imaging routinely in everybody. Especially the point on that is that if the techs, whether it's CT or MRI, are doing perfusion imaging routinely on everybody, as opposed to, once a week or once every couple of weeks, in the case that you decide you need it on, they're going to be slow because they're not going to have the reflexes of how to do it routinely. If whatever you make as the routine in your stroke code process is going to optimize how quickly and smoothly it goes. So we've always emphasized to get as much information as you can because you'll make the correct decisions that way. And that's probably the most efficient way to get the quickest and best quality imaging. We use rapid on all of our scanners, so we get the rapid output that goes to the treating team. Also, I also like to see the scanner generated maps as well. Sometimes that's I see that quicker than I will see the rapid images come back. Although rapid is rapid, but it still takes a few minutes to come back. I hope that addressed the question.
Okay, the next question in the chat box is, explain CT perfusion criteria for giving alpha plates over 4.5 hours after last known well.
Yeah, so we're talking about IV, right? And then based on I'm going to share again and go back to that slide that had that. So it was based on this trial, the Extend trial. Now you've heard of Extend IA, Extend IA TNK. Well, this one wasn't called Extend IV, but that's the way to think about it. It was actually the first in the series in the last report. But here's what it used. It used a rapid defined perfusion target with a core less than 70 mils, a mismatch volume greater than 10 mils, 10 cc's, and a percent mismatch greater than 1.2. And so this was based off a rapid. This was the positive trial. Okay. And, we use something comparable. And then also, whether it's MR perfusion or CT perfusion, this was what they used to include the patients. You need perfusion imaging, obviously. And I would say, particularly, I think the biggest challenge for hospitals that aren't used to doing MRI 24/7 is if you're going to use these criteria, which again, if you want to strictly hold to the clinical trial design, Extend has a time window that closes up at 9 hours. Wake Up doesn't have an upper limit. So I think that the challenge then is if you don't ordinarily have MRI available, that might make it difficult. But if you do, I think you want to start getting out of the reflex habit in the emergency department of getting a CT, particularly getting just a non-con CT, on every stroke that comes in and be a little more selective based on the time window. If the patient comes in and you know when they arrive, the time from last known well is already greater than 4.5 hours, and MRI is possible, then you might want to go to MRI first to see if they're eligible under the wake-up criteria. I think, over the years that early, getting the CT, getting this non-contrast CT has become such a reflex, it's almost hard to stop. But in this area now where we need to do more sophisticated imaging to appropriately treat patients beyond 4.5 hours, beyond 6 hours for thrombectomy, I think there's a little more work that goes into it. And you have more than one path of going to imaging, and it's been done. It takes work, it takes organization, but I think the benefit is you'll be able to treat more patients with certainty than you would otherwise.
Excellent. Okay, another question. Besides MR perfusion or CT perfusion, is there another modality like non-con, CT, aspects, etc., that you feel would be a substitute for DWI?
Well, I think CT perfusion can give you a good estimate of the core. Aspects is tough. I mean, aspects in terms of quantitative lesion volume, I don't think it's going to be that accurate. I think aspects is good for getting an overall sense of the whether it's a big or small area of ischemic changes. Also remember, aspects is just for the middle cerebral artery territory. So if you have an anterior cerebral artery, or you have middle and anterior cerebral artery, aspects is going to underestimate that, or if it's outside of the MCA territory, aspects doesn't really apply. But I think it's good for sort of a more qualitative. I know there's numbers with aspects, but it's more of an ordinal scale than a volumetric scale, right? So I think in aspects, criteria, and threshold have been used in selecting patients for trials, but I'm sure it'll continue to be studied, but I think if all you have is non-con CT, then you need to figure out the best way to apply it. And aspects is some estimate of core. It doesn't tell you whether there's still a penumbra, which is, or whether that is how much of an aspects change in the late window will tolerate thrombolytic without hemorrhaging. I mean, the ideal case is having if you're going to use CT, if you have a clear clinical syndrome and a stone cold normal non-contrast CT, or any early ischemic changes that are very small, so a high aspect score. But that wasn't really the subject in these trials that were positive, and they didn't use aspects to screen people out. They had the perfusion or diffusion measures of core.
Okay, here's a comment from Lisa Word. She says, I'm very rural. We've flown a patient out, or we have flown a patient out over 6 hours, and he did well. We don't always get details of treatment used, but they said the time saved in the air saved this guy. Awesome to be a part of the team. I didn't think he could be saved that far out. Awesome.
Yeah, that is awesome. I mean, those are great stories. I'm sorry they're not giving you feedback. But yeah, I mean, certainly, thrombectomy out to 24 hours, and in certain cases, maybe even later, particularly for basilar occlusions, it's making a big impact.
Okay, another question. In the setting of likely lacunar stroke and inability to obtain timely access to MRI, how would you treat? CT perfusion does not catch these strokes.
Yeah, I mean, it's a great question, really important. So it really depends on your clinical assessment. If this is somebody where you feel, based on clinical criteria, your history and physical, that the diagnosis of ischemic stroke is more likely than not, and all you have access to is CT. Even CT perfusion, as you point out, won't show a lacunar stroke. CTA won't show it. If you're convinced that this is on clinical grounds that this is a stroke, yeah, I mean, the right thing to do is treat in the early window. I think you're going beyond the trials if you use that for wake up or beyond the 4.5 hour window, where you need some. I mean, the trials used some positive imaging indication that this was the right patient to treat.
Okay, here's another question. Is there a routing criteria you would suggest for moving a patient to MRI? And it looks like this is in critical access. No, maybe not. Just for moving the patient to MRI.
Well, I can tell you what we've done at the places where I've been, which is, ideally you get the notification before the patient has arrived from EMS, or you get the call from emergency department. If you get the pre-notification, you give the MRI techs a heads up that we've got a case and is the scanner ready. Once they get there, you do the screening for MRI safety and compatibility. Works really well if the patient is not aphasic. If they're aphasic, you may have to do some x-rays or talk to family. And then just move them over to MRI. So our goal is always to get them to MRI within 10 minutes of arrival. And in that time, we've done a lot of the screening for thrombolysis, so that as they're getting in the scanner, we've pretty much, we've already talked to them or family about, the possibility that they might be eligible for thrombolytics and discuss risk benefits alternatives. So we actually like to have the scan be the last part before we treat, rather than the first part. We get all the other stuff done. It does take longer to get an MRI, but we're treating very few stroke mimics. We're very confident in who we treat most of the time. And if you take that approach of determining all the eligibility prior to getting in the scan, then once you have an eligible scan, you treat right away, sometimes treat in the scanner. That's our approach. There might be other ones as well that are valid.
Okay. We are at the end of our time, but I'm going to ask one more question here. And this is the change in both wake up and timeless. Imaging at the small hospital is going to be critical. And they would like to know how you feel, or what you feel would be appropriate as their resources are limited.
I think if you go by the clinical trial data, there needs to be more imaging screening than a non-con CT. Those two studies by Barreto and the Hopkins group was somewhat reassuring that just based on the non-con there were no symptomatic hemorrhages. But those, they didn't look. We don't know efficacy from there. It was still a small sample. So in the late window, I don't think we can have a lot of confidence just based on a non-con CT. And that's the challenge. If it looks like an ischemic stroke and it's a late time window and it's a critical access hospital, and we have those in our network, we send them as quickly as possible to one of our stroke centers that can do the advanced imaging. Now, luckily, they've had getting back to the point, they've had everything but the imaging to declare them eligible. And so once they hit the door of the stroke center, they'll go right into the scan, see the eligibility. I don't think there's any way around it for the wake up beyond 4.5 hours patient. You're going to need, right now, based on the evidence, you're going to need more than just a non-contrast CT. So that's the situation the hospital is in. You've got to get them to a stroke center as soon as possible.
Okay, well, thank you very much, Dr. Warwick, for a very informative and educational presentation. A lot of great comments here. Everybody's wanting your slides, and thank you for everyone who joined. Our next series will be August 7th. Our next in our series will be August 17th. It'll be field detection of LVO, and that will be presented by Dr. Mohammed Talib, and he is like the founder of the VANS board. So I hope you can join us, and thank you so much for everybody who joined here. We will send you a link to the presentation, and then we also will be posting it on our Southwest Quality website, so you'll be able to get the slides and the presentation. So thank you, everybody. Have a great rest of your day.